Hello and good afternoon. Thanks everybody for joining us at the National Healthcare for the Homeless Council this afternoon or this morning, depending on where you're calling in. I'm Barbara DiPietro. I'll be the moderator for today's session. I'm our Senior Policy Director and really excited to talk about two new resources related to testing events. And we've got a great panel lined up for today. I just want to go over a few ground rules on how all of this works. So you should be seeing the cover slide here advertising our testing for COVID-19 and homeless shelters and encampments. We'll be discussing CDC's new health department guidance and our new issue brief. You should see under that a chat box. So as you have questions or comments for the speakers related to your testing events, please type in there. We kind of want this to be an active discussion. We want to use this not only as a chance to hear from our speakers, but also get a sense of what's going on with you, taking a pulse of the issues that you're seeing in your community. And that way we can try to, as imperfect as this medium is, we can try to at least kind of capture what we're all going through as we're navigating a very dynamic and constantly evolving issue. Just in case anyone should be curious, we are absolutely recording this. This recording will be available to you and to all of your friends and family. We will have the slides available, so if you have registered, all of this will come directly to you. If you're having any trouble at all, particularly with your tech, feel free to type that also into the chat box, and our tech folks, Caroline or Brandon or Cecilia, will help you. And then if you're having, again, any problems hearing or need to get some phone tech, please call Caroline at 615-200-6165 or Cecilia at 615-669-3225, and their information is in the announcements box at the bottom. One more thing I want to just orient us to are the resources box that you should see, where we've advertised both the link to the issue brief, the link to the testing guidance for health departments and the CDC, our COVID-19 TA page that has a lot of resources, and then also a CDC survey on universal testing that we'll be talking about later and that we really hope that you'll be active with. So with all of that said, let's plunge in. Some of this I have already gone through on the testing piece, so my apologies here. But we will just walk through these, and then we want to facilitate a discussion. So really we know what we want to hear about are people who are doing this work in the field, and we can learn from their lessons. Right now, as we've got a lot of testing issues that are emerging, particularly in new communities in the country, we're seeing people being faced with the same questions and the same issues that folks in Seattle and in California and Oregon, as well as in Boston and on the East Coast in New York and here in Baltimore, the things that we've been facing as we just addressed some of this wave in an earlier time than some newer communities. And so how do we learn from those who have gone before us, and how do we make sure that we're able to achieve some efficiencies in making sure that we're operationalizing those lessons learned. So that's really what we want to do today, is make sure we're learning from each other's experiences and making this as best as we can. So just so that we can learn a little bit more about you, we're going to bring up some poll questions. And so for those who are gathered around the computer, it is voting time. So if everybody could Brandon, if you could bring up the first question. And this is just about where you are calling in from. And so what type of agency or organization are you calling in from? So it might be a healthcare for the homeless program, another type of healthcare provider, maybe with local government or a shelter or state government. So it looks like so far it's mostly local government and HCHs, and that's to be expected. But it looks like there's a smattering of other folks in here. We'll just leave this go for just a minute more as we just get a flavor for who's with us here. And I see lots of folks introducing themselves in the chat box. That's really great. Okay, so really it's mostly we're local government and HCHs with some other healthcare providers, and then some COCs in there as well. So, all right, thank you. Next question. We want to know whether you have participated in testing events broadly. So this is not individual patient testing. Let's see, Brandon, I think we're bringing up a second question here for voting. Very good. So are you from an agency or organization that's already conducted at least one universal testing event at a shelter or an encampment. And so just getting a sense of like whether people have been involved in this yet. It looks like a little bit more than half have been doing this or have done at least one so far. We've got half and half now. This is very exciting. And about, okay, some about half and half have done at least one or maybe not yet. Okay, so let's pull that down. And then the third and final question. We just want to make sure that just getting a sense of who's been leading your testing events. And so one of the things we really wanted to talk about in this discussion is how we're leveraging formal authority in our communities to be able to do testing or to get the initiative, the capacity, the funding, all of that. And so in your area, has the local health department or other government authority been a leader in your universal homeless testing events? So for those of you who have had universal testing events happening, what's been the role? Okay, so I'm really excited to see that, frankly, they either consistently been a leader or has not been a leader. And as more people weigh in, it's kind of getting more nuanced. Okay, so definitely we've seen a significant space for local health or other government here, with still about a quarter of folks saying no or about 15% saying they don't know. Okay. With all of that, thank you, Brandon, appreciate that. Thanks for everybody for weighing in, just so we have a better sense of what we're working with here. Let me introduce you to today's panel. Want to talk with Dr. Christine Schmidt, who's a physician with the CDC, normally working in Division of TB, but has been working on the homeless unit for a little bit, and we're really delighted to have her partnership. And then from our HCH and provider field, we have Kevin Lindemuth, who is the president and CEO of the HCH in Baltimore, where I am based, and happy to have my Baltimore boss here joining us for this discussion, as well as Liz Imbert. And Dr. Imbert is coming to us from the San Francisco Department of Public Health. And in San Francisco, the local, the Healthcare for the Homeless program is part of the local public health. So a different organizing structure, and again, I think that can be something that we talk about. So at this point, I have talked for a lot, and what I'm going to do is I'm just going to turn it over to Dr. Schmidt, who can walk us through the new CDC guidance. And at this point, Dr. Schmidt, I'll turn it over to you.
Thanks, Barbara, and thanks everyone for calling in today. I really appreciate everyone's participation in this conversation, which is an extremely critical conversation to be having. So I'm very interested to hear all of your thoughts and your experiences. First, I just wanted to bring to your attention, if you aren't already aware, that CDC has created multiple resources for people experiencing homelessness and homeless service providers that are posted on the CDC website. These guidance documents can be found on the CDC COVID-19 site in the section labeled Helping Communities Plan and Respond. These resources include interim guidance for shelters and homeless service providers, serving both sheltered and unsheltered persons, that emphasize creating a whole community approach to the response as it relates to people experiencing homelessness. These resources also include a checklist of considerations for homeless service providers as they reopen programs and facilities, and the newly released guidance around testing strategies for homeless shelters and encampments that Barbara referenced. And so today I'll briefly highlight some of the contents of the new testing strategy guidance. But please remember that testing is only one component of a comprehensive response strategy and should always be used in conjunction with promoting behaviors that reduce spread, maintaining healthy environments, and preparing for when someone does get sick. It's also important to remember that the considerations outlined in the guidance should always be reviewed in the context of local recommendations and resources. So the interim guidance around testing describes scenarios when SARS-CoV-2 viral testing may be appropriate in homeless shelters and encampments. Testing should be considered for individuals with signs or symptoms consistent with COVID-19 and for asymptomatic individuals with recent known or suspected exposure to SARS-CoV-2 in order to control transmission. Based on the level of transmission within a community, testing can also be considered for asymptomatic individuals without known or suspected exposure to SARS-CoV-2 for early identification in homeless shelters and encampments. The purpose and process of all testing and other public health activities should always be clearly communicated to clients and staff at the homeless service sites to promote understanding and acceptability. In addition, testing strategies should be carried out in a way that protects privacy and confidentiality to the extent possible and that is consistent with applicable laws and regulations. And any time a positive test result is identified, it is critical to ensure that the individual is rapidly and appropriately notified, separated from others, provided appropriate medical care, and linked to appropriate alternative housing for isolation as needed. One additional point that is really important to emphasize before we talk about the different testing strategies is that CDC does not recommend entry testing for homeless service sites. We also want to emphasize that homeless shelters should not exclude people who are having symptoms or who test positive for COVID-19 without a plan for where these clients can safely access services and stay. So the guidance document also outlines how to use community transmission levels to guide which testing strategies to use. For example, in areas where community transmission is none to minimal, health departments should use their standard system and case investigation processes to identify confirmed and probable cases among people experiencing homelessness or homeless service staff. Alternatively, in areas where community transmission is minimal to moderate, health departments can also consider working with partners to increase testing access in homeless shelters and encampments to identify COVID-19 cases more proactively. And then finally, in areas where the community transmission is substantial, health departments may consider coordinating with partners to offer facility-wide testing for all clients, volunteers, and staff in all sites at least one time, regardless of whether an initial case of COVID-19 has been identified in those sites. And then repeat testing of all previously negative or untested individuals, for example, every week, is also recommended until the testing identifies no new cases of COVID-19 for at least 14 days since the most recent positive results. So those are a few of the key components of the new testing strategy guidance. And finally, I also wanted to highlight some additional resources for persons experiencing homelessness and homeless service providers that can also be found at the CDC COVID-19 website, and we encourage you to check all of these out. And that is it for me. I will turn it back to you, Barbara. Thank you all.
Okay, thank you, Kristine. Appreciate it. And again, down in the resources box, if you want to bring up the CDC testing guidance, you can do that, and that will not interfere with the webinar here. And please share that with your partners in your community if they haven't yet seen it. So let's talk a little bit about our new testing brief. So one of the things that we wanted to do was get our hands around what are the strategies that make these testing events successful. There's a lot of pieces that need to come together, and we really just wanted to outline kind of a guide that folks can use. Again, from the earlier on in our poll, it sounded like about a half of you have not yet done some of these testing events. And so as we're putting in plans, thinking about what others have done. And we really also wanted to aim this at public health authorities, emergency response systems, as well, to make sure that we're really working in partnership. We wanted to make sure that the federal testing guidance, particularly that from HHS, from CDC, and from HRSA, also was kind of located in one place so that we have access to the guidance that's out there, particularly if you're a health center, and HRSA is important for your regulations and funding. And then we really wanted to reiterate the importance of conducting testing in this population. We've done prior issue briefs and discussions that talked about how people experiencing homelessness are at increased risk of contracting COVID and of being seriously ill, given all that we know about underlying health conditions, people being older, people being in congregate settings, and obviously not being able to follow public health advice like staying home, washing hands, maintaining social distance. All that's very difficult if you're in a shelter or an encampment or some outdoor location. So we really wanted to make sure that as our communities are talking about transmission rate in nursing homes, transmission rate in detention centers and prisons and jails, that we're also making sure that people experiencing homelessness in congregate settings and high-risk people like this are part of the priority and they're part of the discussion. So I think both the CDC guidance and this testing brief give you some tools to really push that forward. And so again, we really also wanted to talk about what are the factors that you need to consider in terms of operational strategies. What have been some common challenges that folks have experienced and have been doing this? And then what is a series of recommendations on how to move forward if this is something that you're looking to do as a new initiative or if you're looking to improve your existing ones. And I will say that this paper represents just even the 5 focus groups that we did with Boston and Baltimore and Atlanta and San Francisco and Seattle. That represents 237 testing events of almost 12,000 people. And the range of positive results that came from all of those testing events was from 0% to 66% and everything in between. And so I think this is the kind of dynamic environment that we're in. We're figuring out how and whether and where we are testing and who we're testing and what the shelter characteristics are. I think all of that are factors that are going to inform what that percentage looks like for you. So why don't we, and my intention here is just to kind of walk through some of the pieces just so that we're all on the same wavelength here. So from a strategies perspective, we know getting support for testing itself is step number 1. You've got to come to some common agreement that this is going to happen. So how does that happen? How do we get even the political support for that if needed in some communities? Or just making sure that you've got the right partners at the table, and that can be the local health authority or your disaster or emergency preparedness folks. But it could also be a collection of other providers. So we've seen a lot of combinations coming together, your hospital partners, your university systems, your medical schools. Thinking about how frequently will you be doing testing? And that is going to depend a lot. It's going to depend on the testing supplies that you have, the PPE, the partners involved. So a lot of that. Whether and how you are doing contact tracing and antibody testing, a lot of that might be happening through the health department, but communities are in very different spaces here. I had mentioned earlier the shelter characteristics that might drive not only the decision to actually test, but it also might be driving the types of positive rates that we're seeing come back. And then how we're approaching unsheltered or encampments, just to make sure that we are being comprehensive, but that we're also adapting our approach based on where our clients are. Obviously, funding is going to be an important part of this. And so I think there's been a number of funding streams that have come to states and localities to support testing, and HHS has been putting out significant funding for this. So far, I think there's been $11 billion in testing funding that's come through the CDC to locals and states. And in fact, just yesterday, HRSA put out an additional funding to community health centers for more testing. So I think there's a variety of funding opportunities there. And then thinking through what are the services that you are providing when you are doing your testing, and thinking about how you can be making an opportunity to do broader health screenings or to incorporate other goals that you might have in your healthcare services if you're going to be reaching people. And then finally, thinking about what your next steps are. So these are kind of the components that we want everyone to be thinking about as they develop their operational strategies for their testing events. But when we shift over and when we talk through with folks who have been doing a lot of this, what are the common challenges that you have been experiencing in either getting support for doing the testing at all? It may be that you run into a lot of roadblocks for even the support for that. But then it may be, too, that we are discovering, and I've heard this in a lot of spaces, that as new partners come to the table during COVID, and a lot of us are working with people that we weren't working with 6 months ago, that there's been a limited familiarity with some of our newer partners with the needs of homeless populations. I have been present myself, and I've heard other people tell of being on Zoom calls and having folks come to the realization that, wow, these are really sick people. Wow, we really need to do something about folks getting off the street or getting out of the shelter, to which we would heartily agree. So I think that's been a challenge, is kind of working from a baseline information has been taken time to build. Gaining client trust to be tested is something that's very important, gaining consent and trust and understanding what this entails and what either a positive or a negative result will mean for them. We know that there have been challenges in limited tests and capacity to test. I think that's not a surprise to anyone. I think there have been some challenges where people express a lack of confidence in the test results, and certainly that is kind of a piece that is not specific to homeless, but has been a challenge in this broader national response. And then figuring out, like, how can we ensure sufficient services? So making sure that we are really serving our clients in a comprehensive way here and making sure that the testing event is not more traumatic than it needs to be. This can be a very uncomfortable test, and it can really trigger folks in mental health ways, or frankly, in people who don't have those issues, this can be something that can really be stressful. It's also important to know locating vulnerable people, either to do the initial testing or to do follow-up to deliver test results. And then finally, sharing data with each other as partners in a way that respects privacy laws and HIPAA. And I think this is something that's also people have had some workarounds to really thoughtfully think through how do we exchange information in a way that allows, protects client confidentiality, but then also protects public health. So those are the strategies and challenges that people have been reporting to us. And I just want to hit really quick, I appreciate, I don't want to talk too long here, but these are the 12 recommendations that the folks that have come around this table have really said we need to be focusing on. So prioritizing this population, making sure that our partners in our community, our local health department and our disaster response teams, that we're maximizing the legal authority that they have. Remember that individual providers like HCHs don't have the legal authority often to be able to do testing events outside of their clinic spaces. So this is the kind of thing that really might require broader partnerships. And how are we educating those new stakeholders about the needs of our patients as well as the needs of us as providers? And how do we set up the provider and public information? How do people know what's going on? How do we know when there's testing events? So thinking about that. Formalizing partnerships so that we really are working as tightly as we should be. Transportation has been a real glitch for a lot of folks. So either getting people to the testing site or getting them from a testing site back to a shelter or an alternative care site, making sure that transportation isn't what that glitch. If you don't have anybody coming for your guy, then it ends up being a real wrinkle in the process. Making sure that we're talking with people about COVID-19 education, and especially our clients, so that they understand why we're doing this, educating them about infectious disease protocols, how they can protect themselves. How are we providing services at testing sites, particularly behavioral health services? And I know Liz and Kevin will talk about how they've done this to really make sure that we're serving people in the most comprehensive way, in a way that also ensures the safety of everyone involved. We also want to make sure that we're pursuing permanent solutions and we're not returning people to homelessness. How do we use this opportunity in our country right now to be really to getting people off the street permanently? And so as we are building new systems and as we are making decisions about how we're using a lot of new resources, both HHS and HUD resources especially, how are we using those to really achieve permanent solutions and end homelessness for people right now? I think there's a real opportunity there. And there's an opportunity for us to actively be focused on the disparities that we're seeing, not only in our care, but also in testing and in the treatment that follows, and in particular addressing racial disparities. So thinking through how are we over-testing or doing more testing in targeted areas that have been traditionally underserved, I think that's the kind of justice work that we want to see happening with our testing. And again, coming back to how are we sharing data. So this is a lot of information. I just wanted to walk through that with everybody. And then at this point, I think is where we can finally get through some of these formalities and open it up to our panel here. And so at this point, what I will do is I will ask Kevin and Liz just to spend a couple of minutes each orienting us to their organization and what they've been doing on testing, and then we'll plunge into some of our questions and your questions that you've been putting in the chat box. So why don't we begin, Dr. Imbert, why don't we start with you in San Francisco?
Sounds good. Thank you so much. I am so grateful to be here with all of you and share about our experience. So just a little bit about myself. I'm an assistant professor in the Division of HIV, ID, and Global Medicine at UCSF, and since March, I've been activated to the Department of Public Health as part of the COVID response. And in my role there, I'm serving as the Med-Epi lead for our shelter encampment outbreak response team, where we oversee the responses to cases and outbreaks that occur in people experiencing homelessness. So our testing story in San Francisco really begins with an outbreak in the largest shelter in our city at a time in San Francisco when the community incidence was quite low. And at this time, this shelter had over 250 individuals. Most beds were about 1.5 to 3 feet apart. And it started when we found 2 symptomatic index cases. And after our initial case investigation and our person-based contact tracing and symptom screening of the whole shelter, all the residents and staff, we found a few additional cases, and they were widely distributed throughout the shelter. And this prompted us to do mass testing. And in our mass testing efforts, where we tried to test as many residents and staff there, we found 66% of the residents and 16% of the staff tested positive. And among the residents, over half of those individuals had no symptoms at all when we tested them. So this outbreak really highlighted for us the high risk of transmission that can occur in congregate settings where people are sharing bathrooms, showers, meal spaces, etc. And that while waiting for a symptomatic case to occur, it really may be too late to prevent a super spreading event. It also highlighted to us the limited utility of a response that focuses on routine case investigation and identifying close contacts and only testing symptomatic folks, and the utility of mass testing in response to an outbreak. So this was sort of a pivotal moment for us thinking about this, and really highlighted the benefits of mass testing to detect COVID-19 prevalence among people experiencing homelessness, and made us start to think about how active surveillance could play a role in increasing case detection during that infectious pre-symptomatic phase of infection, and possibly reduce the likelihood of transmission events. So since then, we've performed active surveillance testing of all guests and staff in several shelters in San Francisco, and have found low or no cases of COVID-19 in several shelters and navigation centers. And we are offering ongoing active surveillance in shelter and navigation centers in our city to staff and residents. We've also pursued active surveillance in certain dense encampments in our city, where through collaboration with UCSF and other community partners, we've piloted mobile testing with a multidisciplinary team that includes individuals from the community, and we really have followed their lead. So a few take-homes of what we've learned so far, and there's lots more to learn. I would say one is the utility of mass testing in responses to cases detected to really find out what is the true prevalence in either a shelter or an encampment. Keeping the patient at the center of this process, from pre-test counseling to testing to disclosure to next steps for isolation and quarantine, and the importance of building trust and really let the community lead us in how we apply scientific evidence to meet their needs. The importance of deep partnerships with the community to do this work, as well as the importance of really talking about what it means to have a negative test, and that this is not a passport to safety. We really test to case find, but a negative test does not mean that you are safe, or that it should be used, as we said before, as an entrance passport to get into a shelter or to move. Furthermore, we have really learned that when we identify cases, we really need a clear strategy for isolation and quarantine, and that strategy really needs to highlight what the patient and the community prefer for how that's going to look. The last thing I'll just say is that testing really needs to be done with ongoing efforts for prevention and mitigation, including masking, social distancing, and ongoing efforts really to get those who we think are the most high risk for severe COVID into locations where they can truly shelter in place. So I'll stop there, and I'm happy to answer questions later.
Thanks so much, Liz. And Kevin, do you want to give us a quick orientation to your outfit in Baltimore?
Thank you, Barbara. Much appreciation to you and to the Council for this issue brief, and thank you to you, Dr. Schmidt, and the CDC for this shelter and encampment guidance. I'd like to give a shout out to my Healthcare for the Homeless counterparts listening in today. I see lots of Healthcare for the Homeless staff among the 220 of you or so on today's call. Hello to our state and local homeless service and public health partners. We very much encourage your participation in the chat box today. You've all been an important part of this story as well. We're a nonprofit organization and federally qualified health center, Maryland's leading provider of integrated healthcare services and supportive housing for people experiencing homelessness. Prior to COVID, we were serving about 10,000 people a year across 5 clinic sites. We've had to, unfortunately, temporarily close several of those sites, and our overall volume is down about 35%. But we knew from the very beginning that it was very important for us to keep our doors open. Homelessness was already a public health emergency. Our clients, the majority of whom are people of color, were already more likely than their house counterparts to die prematurely. Already dying from hypertension, from diabetes, already suffering disproportionately from higher rates of mental illness and addiction. This is true all over the country. I think our story may be similar to others nationally. We moved the majority of our staff to telework arrangements mid-March. We screened universally upon entry to our clinic. We, like everyone else, were responding to constantly evolving guidance. By late March, March 25th, we had developed our own testing capacity and repurposed the outdoor garage attached to our downtown clinic to a COVID testing site, with our mobile clinic used as a provider clean space, and then 4 testing bays in that garage. We also established dedicated phone lines for Baltimore City and Baltimore County, where shelters who were screening for COVID symptoms could call us for greater assessment, and ultimately, through an evolving collaboration, transport to shelter and isolation. Not including shelter testing, we've completed a little more than 400 tests to date at our clinic site. The average positivity rate is about 30%. At the very height, about 5 weeks ago, almost half of our tests were positive. The state average at the time was about 20%, so more than double that. Now, over the last 2 weeks, our positivity rate has been under 5%. So we are very optimistic, and the state positivity rate is down. Of course, everyone is concerned about the fall, and we join them in those concerns. I think it's important to note that this entire phenomenon over the past 4 months, the story we tell today, is set against a backdrop not of strength, but of significant deficit. Now, we've risen to that. There is strength among us, of course, but over decades, we as a nation have disinvested in public health. We have disinvested in housing, disinvested in social safety nets. We've had centuries of racist housing policies that have placed a disproportionate health burden upon black and brown people. Our public and private agencies were already treading water with insufficient resources to meet the need. Have to remember that. We were already responding to an emergency and didn't have the resources that we needed to address it. And then COVID hit. This is true all over the country and demonstrates quite troublingly that we were ill prepared for an appropriate response to a global pandemic. And this experience must prompt us to reinvest in our public health infrastructure and to look seriously at housing and healthcare not as market commodities but as fundamental human rights. If there's anything that highlights the relationship between housing and health, as our Healthcare for the Homeless colleagues on the call know, it's a global pandemic. Back to you, Barbara.
Well, I think that's a mic drop right there. I think that pretty much says it all. Completely agree. And I think I can feel that from many of us who, yes, hear your words and heartily agree. Let's plunge into some of our collective questions and the questions that we had wanted to work through. In particular, just kind of looking at Liz and Kevin, what prompted the universal testing events in homeless settings in your respective communities? How did you get support for that, and what prompted all of these activities that you've experienced? Liz, do we want to start with you?
Sure. So And initially, we were testing in the first navigation center. We had a case. We tested only symptomatic individuals that we identified as close contacts through case investigation and looking at who slept within 6 feet of someone. So in that case, it was just symptomatic. And then, as I said, after our large outbreak where we were pursuing that same strategy and found several more cases, then we did mass testing in response to an outbreak. Since then, we have done, it's basically in shelters and navigation centers now, we do still get a case history if we have a single case, but then if those individuals, you know, are sharing sleeping quarters, sharing bathrooms, if it's truly a congregate space, then we will mass test in response to that. And then, as I said, we have also done active surveillance, so testing when we don't have any cases, and that's been pursued in several shelters, and we have ongoing efforts we recommend staff testing every 2 weeks for those working in the shelter and navigation centers, and then an ongoing cadence of testing for the residents in the shelters. And then our testing efforts that have occurred in encampments, we have done some testing within encampments, like active surveillance testing. That is an ongoing discussion and don't have a current cadence for how we're doing active surveillance testing in encampments, but we have done that. And then similar encampments, if we have one case, we'll test the whole encampment, and I can go into more details about how we define that, but largely going there and figuring out who makes up the social network in that area.
Thank you. And Kevin, how does that look like for you?
Yeah, and thinking about what prompted universal testing events in Baltimore, it was really a real fear of the rapid spread of an unknown virus among populations experiencing homelessness. We did not know what to expect. We knew that those that we were serving were living private lives in public spaces, sleeping in congregate facilities, that they were more likely to acquire the virus, and that were more likely to get sick and die prematurely because of the presence of acute and chronic underlying health conditions. By mid-April, we had set up a shelter assessment hotline, worked with homeless services and the Baltimore City Health Department to establish, they had set up an isolation motel and our pathway to it. The health department had also set up a process where emergency rooms that were testing people were not discharging into the shelter system, but to an isolation motel and then to a larger isolation hotel ultimately. But initially not much in the way of COVID among populations experiencing homelessness for about a month. And then mid-April, it hit. 5 cases in a residential treatment facility. One of them came to us through a shelter line call. We got them to our testing site in the garage and right away got them to the hospital where they were intubated. And there began a series of conversations, and there weren't enough resources. Nobody had enough tests. Not us, not the health department. 2 days before, we had read the news coming from our friends at the Boston Healthcare for the Homeless program about rapid asymptomatic spread in the well-known study by now that they did. And we said, oh my goodness, we've got a cluster. We've got to go in. So Homeless Services set up a system to take everyone from the facility to an isolation motel 2 days later. We got on the line the next day with the health department, and everyone agreed that this was a good idea. We had just received a shipment of about 50 tests. So cobbling them together with some of the tests we had 56 tests, which is what we needed. We had a promise that once we used them, the lab partner would replenish them, but we were so worried about not having any tests, if we can all remember what it was like then. So we went in, we tested everybody door to door in the motel, and 30 of the 56 came back positive, only 1 symptomatic. So again, rapid asymptomatic spread. We knew at that point, and then 2 days later there was another outbreak. 2 days after that there was another outbreak. And this evolving partnership then moved more into action and brought on others, such as private hospital providers like Johns Hopkins, who had more testing capacity. And then today, the Baltimore City Health Department, and I see our friends on the line here, are really taking the lead in ensuring that we've been able to do universal testing throughout the city.
Great, thank you. And so one of the things, as you both talked about the partners that you use and how this has evolved, when you went to actually do your testing event, how did you approach pre-test counseling, client consent, and disclosure of the results? And I think all three of those things are really important, but I think you would approach them in ways that were unique to your community. Why don't we just go in reverse order this time? Kevin, did you want to start this time?
I mean, this is the question. I think there was a great realization, as you referenced earlier in your review of the paper, Barbara, that people experiencing homelessness are sick. I was really astounded when hearing this realization among our health department partners, even some of our homeless service partners, hospitals, people that have been working in the healthcare space, that when you get a group of people into an isolation hotel to await results or to isolate because they have COVID and they're not sick enough to be hospitalized, there's a lot of other health complications there, prompting us to nod our head and say, yes. So the big question had often been, how is it that you take care of chronic health care problems? And at first it was a bit of a challenge where isolation facilities and some of the private sector partners overseeing them didn't want to take people into them that had other health care challenges. And then I think there was an eventual realization that everyone that we were working with experiencing homelessness had healthcare challenges. And so we found it very important to not just do a test, but to do counseling with the individuals and to do a health screen so that if the person was heroin dependent, we could talk about buprenorphine and starting buprenorphine before they went to an isolation motel. If they had medications that needed to be refilled, we could take care of that before they went. I think there were many experiences in this partnership where that assessment ahead of time didn't happen, and then they get to the isolation motel and deteriorate very quickly, and more healthcare intervention was needed. The isolation hotel today, much larger capacity, University of Maryland and the health department have stronger clinical support and then greater access to our healthcare providers to help manage chronic disease.
Thank you. And Liz, how did you approach the pre-test counseling, the consent, and the disclosure of results?
Yeah, I think I'll echo a lot of what Kevin has said. I mean, I think it's the patient is at the center, right? And when you test somebody, you're starting them on a journey that you need to figure out, what are their other priorities, what are their health needs, and how are we going to meet them on this journey? And then how does their test not only affect them, but affects the community around them? Or how does it affect them when someone in their community is going to test positive? So I think we were very, lucky in the Department of Public Health to have very strong relationships already with community partners who have long experience working with people experiencing homelessness, but also people on their staff who have experienced homelessness themselves, as well as the team that got activated to this work within the Department of Public Health is really the seasoned team who works in our street medicine, in our shelter health, in our navigation program, finding new cases of HIV and syphilis, and doing our, encampment health work. So I think we were really set up for success in that we had people who already had relationships and knowledge and a collaboration there. In the pre-test counseling, we talk a lot about what our script is sort of, what does this test mean? What does it mean if I'm positive or negative? What does it mean if somebody in my community is positive and negative? What does isolation mean? What does quarantine mean? As Kevin said, when you go into quarantine or isolation, there are financial burdens to individuals for that, and so the city has been doing more work on that as well. But also, starting buprenorphine, we did tons of buprenorphine starts, but also figuring out how do we provide alcohol or cigarettes or other things for people to really get through quarantine. And I think quarantine is one of the hardest things to explain, especially it was just very heartbreaking in we had some cases in a shelter where we ended up, bringing everybody out and putting everybody into their own hotel room to quarantine because we were very fearful of rapid transmission. And essentially you're hearing from people like, so you're telling me I'm not safe because I live here. And it was just, it's really hard to explain that. And I think we are really need to create an isolation and quarantine situation that really helps and figures out, how do we meet everybody's needs, how do we fulfill preferences during a very challenging ask that we're asking from a public health standpoint.
Thank you. I think that's really helpful to know. Want to turn to some of our audience questions. Stacy Matthews had asked, does testing reduce the need for quarantine? If a participant agrees to testing at entrance and is found to be COVID negative, can they exit quarantine and enter the general socially distanced shelter area? I would open this up also to Kristine, to feel free to jump in. What are any of your responses, or do any of you have a response to that question?
Do you want to take this, Kristine, or yeah, go ahead.
Yeah, so, and I had actually replied in the chat box, but so we would generally say that if someone tests negative, they can be in the general population, and of course, still doing the social distancing and all of the other recommendations that we have for reducing transmission. That being said, particularly if someone has an exposure and they do develop symptoms, then they should obviously immediately be isolated and arrange for testing to be done. So that's how we would, potentially handle that situation, or recommend handling that situation. But again, I just want to emphasize that we are really encouraging that testing not be a strategy used to allow or deny entry into a homeless service site.
I want to underline that point, that we really work to not in any way weaponize, if you will, testing, or to use it as a demand in order to let an extremely vulnerable person who may be experiencing all kinds of trauma, even at the notion of getting tested, not denying that person shelter because they won't take a test. It was said earlier in this discussion, but it bears repeating. A test is not a vaccine, and I think I can almost see the head nods of some of our health department colleagues listening in, where we've really had to work with some of our shelter operators that almost treat it as such, that, oh, as long as everyone gets tested, then we're all going to be okay. Well, that could change the very next day as soon as someone leaves the shelter and comes back in. And so we really have to remind ourselves that testing gives us a tool. It should never be used as a weapon or as a barrier.
Thank you. I'm conscious that we're coming down to our last 12 minutes, and there's so many things to talk about. If we can shift to talking about contact tracing. I know that this has been something that a lot of folks have talked about, and we had a question in the chat, and some of these may have already been answered in the chat box, but just to kind of make sure that we are comprehensive. Can you please address more specifically how to effectively do contact tracing in the unsheltered homeless community and share test results without violating PHI to local authorities and homeless outreach teams? And I guess as moderator, if I can just expand that to be even like all people that we're testing. So how are we doing contact tracing, and how are we doing the follow-up and data sharing in a way that doesn't violate the PHI? I think this is a probably two issues, but if we can both talk, if you can talk to them, anyone can jump in on this on who wants to go first.
I'm happy to jump in. So I think, you know, contact tracing, and the CDC points this out in their guidelines, location-based contact tracing is really what we're moving towards and what we're doing. So if we have a case in an encampment, we, you know, go out there and figure out, you know, what this encampment looks like. We actually do pre-site assessments in many of our encampments to already learn sort of what those networks are, but obviously that changes day to day with people moving or encampments being cleared. And so the location-based contact tracing is figuring out who is with that individual and then asking that individual, have they gone to other places? Do they also stay in a shelter? Do they go to work? Do they, you know, are there other locations that they go to? And then our approach has been to offer testing to the whole community. In terms of disclosure, we do let the patient really guide us and the encampment guide us in how that looks. And it looks different in different places. And we really let them lead with us in that. You know, our priority is that we do need to let people know that there's a positive, you know, case somewhere in their neighborhood, but we definitely, you know, let the individual and the community help us guide of how to communicate that message. And then I think the other thing that we've learned is that, you know, when people are positive for COVID, it's a lot to take in. And even though we offer isolation hotel rooms on day one, it hasn't in our experience always happened on day one. And so actually, how do we set up support to help people to isolate in place, food 3 times a day, hand sanitizer, water, et cetera, to support that, support them to do that, and then see if they eventually want to come into a hotel. So these have been challenging cases. I would say each case has been very unique, and we've learned a lot. And then in terms of communicating with our providers, we try to use the utmost discretion to protect patient privacy, and have really relied on our, you know, homeless and supportive housing colleagues and other people to help guide us in how do we reinforce to outreach workers and other people in the community who are working with these populations that everyone should act like, you know, people are positive in the community and protect themselves. And so we've actually, you know, updated our guidance on PPE to reflect what people are actually doing to make sure people are safe. And then when we have a positive, it's a very high level discussion of how that gets communicated to the key stakeholders that do need to know on a very as need to know basis.
Great. I know we're coming on time, but does anyone have anything to add to that? Anything more?
Just say that sounds similar.
Yeah.
Sounds similar to what the health department is doing in Baltimore. I talked to, I see Sarah Reeves here on the call, and talked to her recently, where we've shifted, the health department shifted more to a contact tracing model, but we're kind of actively discussing when that then goes to the need to test universally again. And so we're actually sending a couple of swabbers to support the health department to a universal testing event on Tuesday of next week, in result to that process of first intervening with contact tracing and then realizing we're at the point again where we have to do more.
Great. Let's talk about funding. Everybody knows how important this is. So we got a question in the chat box about, is there funding available for shelters to provide testing on their own? How can I access it? I'd like to set up a testing schedule for my staff and residents, but need to access test kits and funding. And I feel like this is an example of folks that have been left on their own to figure this out. And I'm just wondering, what can we do to talk through both the recommendations for someone going it alone as an individual provider, and then also what the resources and funding are for these broader testing events? Kevin, I know that you've been working with this, so I'll just start with you, and maybe others can weigh in.
I certainly understand the strong impulse to go it alone and to develop a capacity, particularly when it doesn't seem that there's other support. When all of this hit, when I think about the partnerships that have developed and strengthened that should have already existed, but over the last 4 months, you had public sector and private sector partners that were essentially treading water and looking at each other like, can you help me? And the other would say, well, I already, my feet are not touching the bottom, so I can't. We've said from the beginning as a private provider, and this may be something that differentiates us from our friends in California, that we can assist the public sector, but we cannot be the public sector. And this sets up a real understandable tension when the public sector has been tremendously under-resourced. So I empathize with the desire, let's just get our own testing capacity in shelters, but I think that really needs to be coordinated in such a way that we build the capacity of the public sector that we all need to have, so that this can be done in a systematic and coordinated way.
Thank you. Anyone have anything to add to what Kevin has said?
I think I'll just say get creative. I mean, I think very early on, we had much more limited testing capacity in our city, and we did partnered with UCSF and really let the research arm and the community collaboration that they led in collaboration with the DPH lead mass testing that really elucidated, what was going on in our city in terms of disparities. And so I think there it's going to look different in every city, but I think that collaboration is key, beyond the Department of Public Health.
Thank you. I know we just have a few more minutes left. We've got time for one more question. We have not been able to get to all the questions, but we haven't specifically talked about unsheltered populations. And so we did get a question in about how do you reach folks who are rough sleeping, who need testing, but do not want to go to a shelter or a hotel to wait for test results. And I know that there's been a lot of issues around consenting to testing, particularly for more vulnerable folks who are outside. Liz, I know this is something you guys have been working through in San Francisco. Do you want to take this first?
Yeah, absolutely. So actually, in speaking about efforts we did with researchers at UCSF, we set up a testing event in the Bayview neighborhood of our city, and we were set up near a location that serves 3 meals a day, and we had barbecue, and we realized we weren't having enough people coming to that. And so we actually stood up a mobile testing team at that time, and we were able to, because we had real deep partnerships with the community leading up to our testing event, where they had gone out and flyed and for many days sort of let people know that we would be testing. They went out with our DPH team and provided testing. And I think some of the key things we learned from that is, one, we brought food, we brought warm food, and we brought gift cards for testing, but actually the food was more of an important thing. And then it was really interesting because our community outreach workers had already been out there. We kind of let them go first and sort of introduce the idea and be the liaison for the DPH team to come in and do the testing on the street. And then I think the other key thing we really learned from that is collecting really detailed information about contact information. So what color is your tent? Where do you stay? Who might be able to find you? That really helped us in actually finding people once we test. So, and then that effort has been duplicated through now our Department of Public Health efforts. But I think that community partnership is super key, and then really trying to not wait till you have a test result to figure out where people are, but trying to figure out how you're going to find them to get them their results up front.
Thank you. I know you're delivering a lot of information very quickly, and we are just about at time. But Kevin or Kristine, do you have anything you want to add to what Liz had just talked about on unsheltered?
Nothing to add specifically other than to note that all of this underscores the incredible need to move people into housing, because our clients over the last 4 months who have been in permanent supportive housing are having a totally different experience and are able to isolate at home. This should drive all of us to invest in housing that's sustainable and affordable for everybody.
Agreed.
Yeah, Barbara, I'll just add that here in Atlanta, our experience was very similar in terms of incentives being very important in engaging with this community, as well as working with the partners that have already been continually engaged with them as sort of our entry points and our points of contact.
Great. Thank you. I know we're right at time. I know folks are going to be dropping off, but I absolutely want to take this opportunity to thank our speakers who have brought such tremendous expertise to this. I really appreciate their work on this, their work in the field, their work with the council. I appreciate everybody who's come to talk with us today. I know your time is very valuable. Just want to make sure that folks are aware that the National Healthcare for the Homeless Council is partnering with the CDC on a testing survey. And so in particular, this is looking at your testing events and the results that you've been getting, the symptoms, the demographics. We are trying our best to figure out how this pandemic is evolving in our population. There is a link to this survey in your resources box. If you are the health department and you can be filling this out, that would be a tremendous help. If you are not, or you and you can share this with your partners in the field who have this information, it would be tremendously helpful to inform the science. And with that, I will say we do have new resources on a new redesigned COVID webpage, so please check that out. And once again, if you have any local guidance, I know there was a number of discussions in our chat box about data sharing and what are your protocols for doing testing, sharing data, putting these events together. If you can share those with Michael Durham, our TA manager, we are putting more and more of that on our site so that, again, that people can be learning from the experiences of others. With that, I will close us out and just say thank you again to our speakers, to everyone here. I hope that everyone has found this to be helpful. When this closes out, you will get an evaluation where you can give us some feedback on this discussion as well as other discussions you would like to be a part of. And so with that, I will bid you all adieu and good luck in all of your testing events to come.